All right, so for chapter 16, we're going to transition away from mom and all of her postpartum adjustments and the family unit, and we're going to focus more on baby, and we're going to talk about the physiologic and behavioral adaptations of the newborn. All right, if you remember when I was talking about, going skin to skin with the baby coming out, and I said the baby's pretty alert to begin with, we look at this as the first period of reactivity in our neonate. This time frame is going to last for about 30 minutes or so, and the baby's heart rate is going to increase up to 160 to 180. It'll drop back down again after that reactivity period wanes and goes down. Breathing on the baby is going to be a little irregular, 60 to 80 breaths a minute to begin with. Now, we're not to kypnic yet because we are making this transition to extrauterine life. If we sustain a respiratory rate of 80 later on, then we've got issues. But for right now, 60 to 80 irregular in that first period of reactivity is normal. There will be a decrease in your motor activity after this initial period of reactivity, followed by anywhere from an hour to an hour and a half, a little bit more of sleep. You may hear fine crackles, you may hear grunting, you may see a little nasal flaring. These things, kind of like the high respiratory rate, they should subside within the first hour of birth, okay? If the grunting, the crackles, the nasal flaring, the tachypnea, if that continues, then your baby may be experiencing some respiratory difficulties or entering into some respiratory distress, which would definitely warrant further surveillance and provider involvement. So your second period of reactivity is going to come along somewhere generally 4 to 8 hours after the birth, and that's a pretty big time frame. Again, because they're reactive, they're awake and alert. Tachycardia and tachypnea are going to be present. Generally, the meconium is going to pass within the first 24 hours, but during this second period of reactivity, you can expect to see meconium passage. You will have an increase in the muscle tone, changes in skin color, mucus production. All of these things are going to be very typical in this second period of reactivity. Now, I know y'all have heard me say multiple times that neonates are respiratory driven. Okay, they have got to breathe, initiate that breathing, take that first breath before anything else is going to kick in. If they're not breathing right, their heart's not going to be right. And if their heart's not going right, they're not perfusing, nothing's going to go well. You may see apneic pauses in their breathing, and as long as it's less than 20 seconds, then that's just a natural process, okay? If it's apneic periods more than 20 seconds, then we have issues. We talked about the grunting, the retraction, nasal flaring. For a little bit, that may be acceptable, okay. It's when they have that persistent that can be signs of pending respiratory distress. Your apneic periods are going to tend to occur in tandem with your REM cycles. And as we said, periods that are longer than 20 seconds should be considered pathological and reported to the provider. When you're looking at the breathing, that paradoxical or the seesaw breathing, that's an exaggerated rise in the abdomen with respiration as the chest falls. So you're going to see that seesaw back and forth kind of breathing. The pulmonary lymphatic system must remove large amounts of fluid from the newborn lungs. Okay, you got to remember, just coming through the birth canal and the compressions of the contractions and squeezing through the vagina, all of that is going to help remove a lot of those lung fluids as well. So, your person who underwent the cesarean birth If they didn't have the baby go through the birth canal and the contractions and the squeezing, then there's obviously going to be some more issues in their lungs for the fluids. Babies are obligatory nose breathers, okay? So when you're suctioning your baby, you should suction the mouth before you suction the nose, because if there's something in their mouth and you stimulate their nose, they're going to and suck up, and they could theoretically aspirate anything that's in there. So you always want to make sure that you clear the mouth out with the bulb syringe before you go to the nose. And I remember that because M comes before N in the alphabet. Okay? Depending on where they are in their maturity, you remember the surfactant in the lungs that's necessary for the alveolar stability. If you have inadequate surfactant levels, then your lungs can't stay open, so you're going to have respiratory distress. So the age of the neonate at birth is going to be very, very important. Your baby's breathing is largely due to the diaphragm contracting, and this gives rise to the norm of abdominal breathing in the newborns. When inspiring, the chest and the abdomen will rise together. However, because the baby has a bigger abdomen, just the size of the abdomen in general, a lot of times prevents that noticeable chest rise. So babies do employ both abdominal and diaphragmatic breathing for their respiratory system. So what kind of changes cardiovascular-wise does my fetus make when it becomes a newborn? Well, you got to remember they've got a lot of things that were open, you know, your foramen ovale, patent ductus arteriosus. What are we going to do with these things? Well, increased pressure in the left atrium is going to force closure of the foramen ovale. The increase in the O2 that's circulating is going to promote constriction of the ductus arteriosus. When they apply the cord clamp on the umbilical cord, the constriction of the umbilical vessels is also going to help close off the ductus venosus. Your umbilical vessels and your ductus will actually then convert into ligaments. When we're thinking about heart rate and heart sounds, you're going to be checking an apical heart rate for a full 60 seconds whenever you are assessing your neonate. Typically, you're going to have a apical rate of 100 to 160. Now, during sleep, it can drop as low as 85 to 90, and when they get crying, agitated, and just full out angry and blowing, it can get up to 170. When you are auscultating for your neonate, the PMI, the point of maximum intensity, is going to be at the fourth intercostal space at the left midclavicular line. I'm going to say that again. The PMI is at the fourth intercostal space at the left midclavicular line. When you're listening to your neonate's heart, hearing murmurs is not always unusual, okay? Most murmurs heard in the first few days aren't going to have very much pathological significance, and 50% or more will resolve by the time the baby's 6 months old. However, if you have murmurs with other associated signs, say they're cyanotic, they're poor feeders, they have apneic periods more than the 20 seconds, their color's bad, anything unusual in association with that murmur, that needs to be reported and investigated. Blood pressure is not routinely checked once you get your baseline unless there's a concern, all right? So typically blood pressure on your neonate is a systolic 60 to 80 over a diastolic of 40 to 50. There is controversy over doing blood pressure checks in all four extremities. Coarctation of the aorta, coarctation defects do not occur occur in the immediate post-delivery time, they're really going to present anywhere from 12 to 14 days later. Blood volume is typically 80 to 85 milliliters per kilogram in the term newborn. At birth, that volume is going to be around 300 mLs. It can increase almost 100 mLs depending on the length of time before cord clamping occurs. So you can have increased blood volume with delayed cord clamping. There is a controversy regarding delayed cord clamping, however. If the delay is greater than 2 minutes, there have been reports of polycythemia with resultant hematocrits of 65% or more and a plethoric or a ruddy color and appearance to the neonate. Clamping less than 2 minutes has been reported to improve iron status in the newborn and has been able to have a beneficial increase in the hematocrit levels. At birth, the red blood cells and the H&H are higher in the neonate than in the adult. In the neonate, fetal hemoglobin is predominant, with the hemoglobin values being between 14 to 24 and your hematocrits running anywhere between 44 and 64. A white cell count of as much as 18,000 may be seen at birth, and this could be considered normal. However, true infections are challenging for the neonate even though you have the leukocytosis present. The reason is leukocytes are too slow really to recognize infection and fight the way that they're supposed to. So with sepsis, there may be a rise in your WBCs. However, some newborns will exhibit clinical signs of sepsis with a negligible increase in their white count. Platelets are going to range between 200 to 300,000, the same as adults. However, when you think about clotting and platelets and just clotting in general, babies don't have vitamin K necessary for clotting. They can't synthesize the vitamin K because their guts are sterile and they're missing the intestinal bacteria that is needed for that process. Because of this, a standard treatment is to administer the aquamaphytin, the vitamin K shot for clotting. And then cord samples of blood are taken to determine the ABO-RH of the neonate. So especially if you've got an RH negative mom, we need to see what the RH status of our baby is. Cold stress is a #1 concern for the transitioning newborn. If cold stress occurs, the baby may experience respiratory distress. It could either maintain, fail to close, or could reopen the ductus arteriosus, may experience metabolic acidosis or hypoglycemia. Each of these things may occur in tandem with one another. So what does the baby do to keep warm if cold stress is such a concern? Well, first of all, I want you to think about the position of the baby. All right, think about you. When you're cold, think about being in class. Don't you kind of huddle into a ball, or at least hug yourself to try and stay warm? Well, the neonate goes into a flex position, so it tries to pull its extremities in and preserve its core temperature. So it'll pull the arms across the chest and it will pull its legs up, kind of folding into himself. Brown fat is unique with our babies, and the brown fat will be burned for heat production to conserve energy expenditures with shivering. Deposits of brown fat can be found over the interscapular region, the axilla, and deep deposits internally, like around the kidneys. Cold stress will rapidly deplete brown fat stores in our neonates, so we don't want that to happen, okay? Also, the amount of brown fat that the baby has in reserve correlates directly with the neonate's gestational age. So if you have a term neonate, they theoretically will have laid down more brown fat stores than your preterm, which is a pretty prime reason why your preemies are at such high risk for cold stress and have such difficulties maintaining their temperatures. As much as we worry about the neonates getting cold, they can also get too hot. The babies are not able to sweat because their sweat glands aren't functioning well yet. So the glands are there, they just don't work. If your neonate overheats, it will result in dehydration, and then that dehydration can lead to cerebral damage and, sadly enough, even death. So you can think about all the news where the babies are getting overheated and stuff like that. It can happen in the neonate. So we have to be careful about getting them too hot the same way that we have to be careful about them getting too cold. Our baby's going to lose heat through 4 different methods, okay? Convection is heat lost into the ambient air, okay? So it's just going off into space, so to speak. Radiation is when the baby will lose heat to a cooler surface that is not in direct contact with the baby itself. Evaporation is heat loss through vaporization of liquid that's on the skin. So stop and think about one of the first orders of business when the baby is out is for the nurse to take a blanket or a towel or something and to dry that baby off and then get rid of that wet blanket and have it in a drier blanket. Conduction loses heat through direct contact with a surface that is cooler. So if you lay the baby down on a table or a scale, if you don't have it covered, then the baby is going to lose heat into that object. When you're changing the diaper or the mom's changing the diaper and they look at it, they may ask what's wrong with their baby if they see pink or orange staining in the diaper. This process, we call it brick dust for a presence and a description. It's caused by the large amount of uric acid crystals excreted by the kidneys during the baby's first week of life. Typically, your baby is going to lose somewhere between 5 to 7% of their total body weight in the first 3 to 5 days. This is going to be associated with voiding, stooling, just an increase in their metabolism, and a limited fluid intake because they have pretty small stomachs. They're not going to just be sucking down everything you can give them to begin with. So what's going out is probably going to be more than what's coming in. A weight loss of more than 7% may indicate poor feeding in your baby and is going to warrant further assessment, especially if you're breastfeeding, because you can't see exactly how much that baby's taking in. If they are bottle or formula feeding, then you can measure it. With breastfeeding, it's not always that easy. A good kind of like basic rule of thumb that we utilize is if the baby has 6 to 8 wets or wet diapers a day after the first few days, we can presume that the baby is adequately hydrated. So its fluid intake should be sufficient. Now in this image, you just see a depiction of skin to skin with the mother and her newborn. Skin to skin minimizes heat loss and is one of the best ways to promote thermoregulation in the baby. A mother's chest, just in that central zone where the baby lays, has the capacity to either increase or decrease temperature in just that spot by as much as 2 degrees. So you can imagine how effective that skin-to-skin intervention will be in promoting thermoregulation. Now, other people can do skin-to-skin. Your dads can do it, your grandma, your aunt, or whatever, but it's the mother and the response in the mother that is going to have that adjustment in her temperature to help stabilize her baby's temperature. All right, so here we can kind of map out what happens physiologically to the neonate that experiences cold stress. So if we get cold, we are going to have an increase in our O2 consumption. You got to think about it. The baby's shivering. Is it burning brown fat? What's happening? It's going to use up oxygen to fuel that. Well, increased O2 consumption means I'm going to increase my respiratory rate, right? I'm going to get hypnic because I'm trying to get more O2 inside of me. I am going to have a couple things happen. I'm going to have a pulmonary vasoconstriction and a peripheral vasoconstriction. So I'm clamping down on everything because I got to figure out where do I want this oxygen to go, what's important that, I supply it to. So if I have the pulmonary vasoconstriction, I'm going to have a decreased O2 uptake by the lungs. And if I have peripheral vasoconstriction, I'm going to have decreased oxygen perfusing to my tissues. So if I have that decreased oxygen uptake by the lungs and oxygen in my tissues become hypoxic, then I'm going to have an increase in anaerobic glycolysis. So to burn up the sugar and get the energy, I'm going to go into an anaerobic because I am hypoxic. Well, we know with the anaerobic metabolism, we're going to have a decrease in our PO2, we're going to have a decrease in our pH, and if you have a decrease in pH, you have an acidosis. And because this is an anaerobic process and the hypoxia is going into the tissues, we are going to have a metabolic acidosis. So moving on into the GI system. Most enzymes needed to digest the carbohydrates, the starches, and fats, the baby's going to have at birth. However, amylase and lipase are not present. Amylase is what's needed to convert starch into maltose, and the lipase is what is utilized to digest fats. So because it's missing these two things, the newborn digestion is limited to your simple carbohydrates and your simple proteins. We talked about earlier there's certain bacteria missing in the gut, so that's one of the reasons we have to give the vitamin K, because the baby is not able to synthesize that right away. The cardiac sphincter that keeps stomach content in the stomach is immature. So that is why your baby, especially if it overeats and overfeeds, it's going to be more likely to spit up and regurgitate. For your baby to be able to suck, whether it's breastfeeding or bottle feeding, it does it with a coordinated breathe, suck, swallow mechanism. So you'll see them go, and I know that y'all may have heard that. You should see me do it. But they have to breathe first, then they suck, then they swallow, and then they breathe again. These stools are going to transition in color, texture, appearance as they go through feeding, okay? And especially if we are breastfeeding. If you look page 466, box 16.1, it's going to break it down for you. Your meconium stools are going to be that tarry, greenish, black, sticky. You have to remember the meconium that was in the intestinal tract, it wasn't moving, it was just there, kind of sludgy. The colostrum, that liquid gold, serves as a laxative. It will help move it out. Then we get into the transitional stool. So it's going to be lightening up a little bit. It's still going to have that little tinge to it, but it's going to start getting that greenish yellowish kind of tinge to it. And then when we get into our milk stools, if you have a breastfed baby, it's going to be kind of like a pale golden yellow, and it's going to be what we call seedy. S-E-E-D-Y. It looks like it's got maybe little sesame seeds or something in it. Breast milk is designed to be completely utilized, digested, and then utilized by the body. So there's not a whole lot of waste product in it. So you're not going to have like formed poops. compared to formula feeding, which is not able to be broken down, metabolized, and utilized as effectively as breast milk. So your formula-fed babies will have larger formed and really malodorous poops. Your breastfed baby is going to have thinner, seedy, and not quite as smelly poops. You need to be aware of feeding behaviors and feeding cues for your baby. If they start sticking their tongue out, smacking their lips, sucking on their fist or anything like that, that's generally an indication that they are ready to eat. While in utero, the fetus begins storing iron for the first few months of life. So at birth, the neonate should have enough stored iron to last for 4 to 6 months. Because the neonate loses its maternal glucose supply, there's going to be a decrease in its blood glucose level until feeding has been established, and he will ingest his own glucose supply through the colostrum or breast milk substitutes. So initially blood sugars will be 50 to 60. They're going to stabilize out at 60 to 70 somewhere around day 3. Jaundice, or that orangey yellow tint to the skin or sclera, does not typically present until or unless the bilirubin levels are 5 or more. Identify jaundice in the first 24 hours, or jaundice that doesn't resolve within 7 to 10 days of birth is going to warrant reporting and investigation by the provider. And we've already mentioned the immature gut, inability to synthesize vitamin K because we are missing the bacteria, and so your baby's going to receive vitamin K IM. Your babies are going to receive passive immunity from mom that's going to cover them for about the first 3 months of their life. Remember us talking about the Tdap in the 3rd trimester for mom, so that the protection for the baby will be there when the baby comes out. So this is kind of an example for that. For other aspects of immunity, the immunoglobulins are as follows. Your membrane protectant IgA is missing from the respiratory and the urinary tracts, and unless the baby is breastfed, it's going to be missing from the GI tract as well. So breast milk will give you your IgA component. Approximately 40% of your adult levels of IgG will be synthesized by age 1, and your IgM adult levels will be reached somewhere around the 9-month period. IgA, D, and E levels are not achieved until early childhood, pretty much because their increase is more gradual. Now remember, we did say that for the gut, if you're breastfeeding, you're going to get the IgA protection just for the gut there, okay? Vernix is that thick, cheesy substance. It serves as a skin protectant while the baby's in utero. There's really, truly no need to wash that off, even though we always do. Really, a good thing is to just massage it in and leave it in the skin, because it does have protective properties, antibacterial properties as well. In your preemie, the vernix is going to be abundant. In your term baby, you're going to see vernix pretty much just in creases of the extremities, in the folds, in the neck, behind the ears, places like that. Acrocyanosis is the condition of central pinking up with cyanotic extremities, especially hands and feet. So the core is going to be pink, but the arms, legs, feet are going to be a little blue tinged. The acrocyanosis is the reason that most babies are going to receive a non-APGAR. They'll lose 1 point for color because they're never completely pink. Lanugo is that fine downy hair that's going to cover the baby's face, shoulders, and neck. And again, this is something more prevalent in your preterm newborn as compared to your term newborn. The milia are the little fine white pimple-like bumps on the face. We don't want to pop them, pinch them, anything like that. Just leave them alone. Skin creases on the palms and the feet are normal. A single palmar crease is referred to as a simian crease, and you can see that in your Asian newborns, or you can see it as a sign presentation structure associated with Down syndrome. All right, your caput is easily identifiable. It's an edematous area of the scalp, most commonly found on the occiput. Your caputs will generally disappear in 3 to 4 days, and neonates who are delivered with vacuum assistance, it's not unusual for them to have a caput on the side of the vacuum application because it just kind of sucks it up. The cephalohematoma is a collection of blood, okay, hematoma, between the skull bone and its periosteum. It is not going to cross the sutures as compared to a caput, which will cross the suture, okay? Your cephalohematoma often occurs with a caput, and there may be an associated jaundice seen in the newborn as the hematoma lyses and the red blood cells break down, and you have hyperbilirubinemia as a result. Your identification of bleeding into the subgaleal space for your subgaleal hemorrhage is critical. I mean, early detection is just beyond vital. Serial head circumference measurements and inspection of the neck are going to be important. If you see a boggy scalp, if you have pallor, tachycardia, and increasing head circumferences, these could be indications of a subgaleal hemorrhage. This will cross your suture line, and it is going to extend down into the neck, which is why you have to do your neck assessments and inspections. Your Mongolian spot, you can see here in this picture, it's just the little bluish, blackish kind of almost birthmark. It's common to your Mediterranean, Latin American, Asian, and African ethnicities. So your darker skinned people, this is common. However, it may occur in 5 to 13% of your Caucasians as well. Generally, the spots are going to fade out, but it may take months, even to a few years. So it's important to know where it is going to present, on what ethnicities, what populations it may present in. So if your parents aren't familiar with it and they see what looks like black and blue spots on their baby, you can speak to them and let them know, no, we're not hurting, injuring your baby. This is what it is. Other things that can happen with the skin are going to be the stork bites. There are small pink areas on the face and neck. Typically are going to fade by the 2nd year, but you can see it's just kind of like at the back of the head, the occiput there where it meets into the nape. You can see it there. Your erythema toxicum, this is your newborn rash. It is a normal process. There is no treatment or cure for it because it's a normal inflammatory process. You just need to observe it, be alert to it, and educate the parents about it. Your port wine stains, you can identify these because they do not blanch with pressure. As in the picture here, you can see that they're found on the face and the neck, and it is usually smooth, and even with the contour of the skin, it is not going to be elevated and palpable. Alrighty, so the reproductive system. Your females, remember, their ovaries are there. The eggs that they are going to have, they're born with, okay? So all of that is already in place whenever they're born. Because of circulating maternal estrogen, you may see some pink tinged vaginal secretions, almost like a little what we call pseudo menstruation. That is normal. It is due to estrogen influence from the mom. The external genitalia, the labia, are probably going to be swollen and full. That is normal in your female. For your male, testes should be descended into the scrotal sac. The scrotum should have rugations on. If you have an enlarged scrotum and it appears boggy, you can actually transilluminate through it. So you could turn the light off, you could take a flashlight, shine it behind the scrotum. You'd be able to see the orb that is the testes in there, but you would also see an accumulation of fluid, which we refer to as a hydrocele. For your babies, their breast and breast tissue is probably going to be a little prominent, a little swollen. This is normal. And you may even see witch's milk, which is just a very thin discharge from the breast that's typically going to resolve as the maternal hormones that are circulating from the baby being in utero has been eliminated. Remember, babies, when they're born, they're pretty malleable, right? And a lot of flexibility is going on. That's because their skeletal system at birth is more cartilage than ossified bone. Their head circumference is about 25% of their total body length, and the head typically is going to measure 2 to 3 centimeters larger than the chest. And we'll talk a little bit later on about the measurements. For the baby and the skeletal system, one of the big things that we look at is the possibility of hip dysplasia. So to assess that, the Ortolani test is done with abduction of the hips to see if there's any clicking, sliding of the joints there. We will look for the symmetry in the gluteal and the thigh folds of the baby's legs. And then there's something called the Alice sign, which is when you've got the baby on its back, knees flexed, the knees are not going to be even with each other. So if you've got one that's abnormal, it's going to be offset from the other. Your digits, if you have polydactyly, poly meaning a lot of or excess, so they're going to have an extra digit. Where their pinky is, there may be an extra digit that is sticking out to the side of that. Syndactyly is when there's webbing between the fingers. Now, in the case of polydactyly, if it is just soft tissue, if the appendage has no bone in it, then the provider will simply tie it off with a suture and we'll just let it fall off because it will lose blood supply. It'll just fall off. If there is bone in it, they will actually have to have a surgical procedure to remove the extra digit. If they have syndactyly and there is webbing, then there is surgical procedure to actually cut through the webbing and separate so that they have freedom of movement in all of their digits. So here you can see the signs for checking for hip dysplasia that we talked about. In figure A, you can see the shortening of the thigh and the asymmetry between the gluteal and the thigh skin folds. In B, they're demonstrating the Ortolani test, looking for your hip abduction. In C, this is the Alice sign, the unevenness of the knees when they're in a flexed position. And then looking at D one more time, they're looking at the femoral head to see if it slips in and out whenever they're doing Ortolani's test. I want you to make sure that you review table 16.3 in your text. It's going to cover 3 or 4 different pages. I want you to look at the different reflexes of the neonate. Each of them are important, but reflexes that we do tend to focus on in general are going to be your grasping, your Babinski, your sucking and rooting, the Moro, the walking reflex, the tonic neck, or it's called fencing reflex and the startle reflex. Your rooting reflex is almost impossible to elicit after a feeding, okay? Because the baby's been rooting around to find a food source. Well, now I found it, I'm satiated, I'm done. It's important that you caution parents against taking the baby straight to the nipple. Rather, let her root around for it and find it. That's also going to help stabilize behavioral development and psychological advancement. If the fencing reflex, the tonic neck, where if you lay him down, turn the head to one side, arm goes out, leg goes out, the other side curls up. If that persists beyond 6 weeks, there may be a cerebral palsy. In the Moro, the arms will abduct and extend, and the fingers are going to come together with the thumbs and kind of make a C. Then embracing as the arms abduct back over the trunk and the neonate returns into a relaxed position. If you see an asymmetric response to this, it could indicate a brachial plexus injury. Stepping or walking response is going to be seen when you hold the baby upright and they have a foot that's touching the table or any surface, and they will step and walk when they have that. That's normally going to be present for 3 to 4 weeks. Your term neonates will actually do the stepping and walking on the soles of their feet. Your preemies are going to do it on their tiptoes. Babinski is a reflex that should disappear by 1 year of age, and the absence of this reflex is going to warrant a neurological evaluation. Remember, for your Babinski, you're going to stroke from the sole, from the heel running up on the outside of the sole, and then you're going to flick across the ball of the foot. A normal Babinski response is the big toe is going to dorsiflex. All of your toes are going to hyperextend. That's what you expect to see in the neonate. And then the startle response is more easily elicited in your preterm neonate. They don't have the adaptation abilities and the calming, the wherewithals, so they're going to startle a little more easily. When you're doing your assessment, you're going to start at the top and you're going to work your way down. All right. So in doing your vitals, a newborn temp is going to range anywhere from 36.5 to 37.5 centigrade axillary, and it should stabilize somewhere 8 to 10 hours after birth. You don't use a temporal or intra-auricular thermometers on these temp tests because they're not effective in the neonate. So you do the axillary screen, excuse me. Blood pressure is not routinely assessed, we mentioned this before, unless you suspect a cardiac anomaly. So you can get your baseline, okay, go ahead and do your first initial, but then you're not going to continue to do your routine blood pressure assessments. However, normal ranges with your blood pressure, once you get your baseline, you would expect 60 to 80 over 40 to 60 initially, with increases to 95 to 100 over 45 to 75, somewhere around day 10 or so. When you're weighing the baby, remember heat loss. You want to make sure that you cover the scale surface with something. Zero the scale out with the protectant cover on it, then you're going to weigh the baby. When the baby's on the scale, keep a hand over, don't touch it, but just kind of hover over the baby for safety, because if the baby jerks, spasms, whatever, you don't want it to fall. When you're looking at weight determinants, anything less than 2,500 grams is going to be considered small for gestational age. Anything over 4,000 is going to be large for gestational age. When you're weighing the baby, you need to remember to obtain the weights at the same time of day every day. Head circumference is measured at the largest diameter, the occipitofrontal diameter. Your head circumference and chest circumference are about the same for the first 2 days after birth. If the head circumference is greater than or equal to 4 centimeters more than the chest circumference, you have to start wondering about hydrocephaly or some other abnormality. When you're measuring length of your baby, you want to make sure you run the tape from the crown all the way down to the heel, making sure to include the length of the legs in the overall length measurement. For your chest measurement, you're going to take your tape and you're going to place it at the nipple line. Average assessment findings are 2 to 3 centimeters less than the head circumference, or 30 to 33 centimeters for your chest. Chest circumference is not continuously assessed on routine exam. It's just done initially. Skin assessment, you're going to look at the color, you're going to look at hair distribution, you're going to look for skin peeling, and then you're going to check for creases. If you're looking at color, remember jaundice is going to be identified when the bilirubin levels are greater than 5. The lanugo will be seen in the preemie, which shouldn't be seen in the term. Look for birthmarks. And remember the Mongolian spot that we talked about? Look for port wine stains, stork bites, anything like that. Remember the acrocyanosis is a normal finding right after birth. That baby's not going to be pink all over. It's going to be pink centrally in the core. If there's a green tint to the skin, there may have been meconium staining in the amniotic fluid. And if it happened kind of early enough, then that meconium actually stained the baby's skin. You're going to look at the soles of the feet for creases, and that's going to help with your assessment for gestational age. In your term newborn, creases on the feet are going to be present on about 2/3 of the sole. Peeling and parchment-like skin may be seen in your post-term baby, whereas your premature baby may be thin-skinned, a little ruddy because the blood vessels under the skin are going to be very easily identified and prominent. Look at the eyes to see if the shape of the eyes are the same. Are they lined up with each other, and do they track the same way? In a pseudostrabismus, the epicanthal folds cause the eyes to appear out of alignment. However, when you check the corneal light reflex, you will see that indeed the eyes are symmetrical to each other. If you have low-placed ears, this can indicate genetic anomalies, mental retardation, or even kidney disorders. The baby may have a preauricular skin tag or even a sinus in front of the ear, or it may just have large protruding ears. You've seen that on babies. You may have noticed the nurse, when she's doing her assessment, puts a gloved finger in the baby's mouth. Now, yes, this checks for a suck reflex, but she's also checking the palate for any cleft malformation. So she can actually see, is the soft or hard palate, is it intact or not? When you're looking at the tongue, look underneath and check the frenulum to make sure that the tongue is freely movable and the baby is not tongue-tied. Because if you see a shortened frenulum, then the tongue can't extend and it can't cut under either the bottle or the breast nipple, and it's going to interfere with the ability for the baby to suck and to feed. You also want to look to see if the baby has a distinct prominent chin, or is the chin recessed back. We call that Pierre-Robin syndrome, and if you have that, then your baby may have difficulty with nursing, swallowing, and even if you had to do anything like neonatal resuscitation, it'd be very hard to get an airway down. When you're looking at the abdomen, you want to make sure that there are no defects at the cord insertion site. You will be able to feel a pulse at the base of the umbilical cord. Same way you could feel a pulse over the artery or over a fontanelle. You're going to look at the umbilical stump and assess the umbilical cord vessels. Remember, 2 arteries and a vein. If you have a gastroschisis, this is a herniation of the abdominal contents at the side or the top of the cord insertion site, and it's not encased in a sac compared to an omphalocele, which is herniation of the abdominal content, but it is enclosed in a sac. Each of these babies, it will be identified, known. The anatomy ultrasound should be able to pick that up. These babies are going to be delivered by cesarean birth. Bowel sounds on your baby will be heard within minutes after delivery. Meconium, typically within 1 to 2 days, it's going to pass. Okay, so within 24 hours, you should have that passage. Remember from the beginning, that second period of reactivity, it's not uncommon to see it pass then. As we discussed previously, you want to be sure that you assess the genitalia and the extremities for any abnormalities. You know, a male with enlarged scrotum, that's not a good thing, okay? That is a potential bad thing. You have to worry about a hydrocele. Then you're going to assess the anus. You want to make sure that it is patent and that there is good sphincter tone. So the anal wink, if it's present, you can say that there is good tone. Now, babies see best at a range of about 8 to 12 inches. It is standard protocol and care treatment for the erythromycin eye ointment to be administered. It doesn't hurt them, and it is necessary preventative maintenance against infection. While, you know, we seem to like the sweet, pretty pastels, the yellows, the greens, the pinks, and the blues, those colors that we associate with babies, if it was up to the baby, everything would be black and white. Okay, so they prefer that over a color, and they like bold, vivid patterns. You know, Rachel's nursery was in teddy bears. She could have cared less if it was in teddy bears. It could have been black and white checkered flags, and that would have been better for her. Taste buds are working in our babies, and the babies will respond to anything sweet by sucking, and if you give them something sour, they're going to grimace. If you give them something that is tasteless, you're not going to get a response. I thought that was pretty neat. Your newborn learns its environment through touch and taste and responds to touch stimuli all over the body, especially hands, feet, and mouth. Now, we talked earlier about the newborn identifying the smell of amniotic fluid left behind after skin to skin, because it has the ability to differentiate smells. It'll be able to differentiate his mother's milk from any other mother. Once the amniotic fluid has drained out of the ears, the newborn's going to be able to hear as well as the adult would. Loud sounds greater than 90 decibels will elicit a startle response in the newborn. If you have a low-pitched sound, that's actually going to be soothing and can lull the baby almost into a sleep state, whereas your high pitches will elicit an alert response. Hearing loss is a common major abnormality after birth, with approximately 1 to 3 of 1,000 experiencing bilateral hearing loss. So in order to screen for this, all babies have a newborn screen before discharge from the hospital, and if there are any concerns, they are always reported and followed up. Temperament is an individual's characteristic level of emotional excitability or intensity, and is typically recognized within the first few weeks after birth. It is often assumed to be an early indication of personality, though personality combines temperament with experiences to shape lifelong traits. So you can't really say what they are to begin with is really what their personality is going to be. For the majority of infants, temperament falls into one of three pretty big categories. Difficult babies are often irritable and fussy. They are upset easily, may be unpredictable when it comes to feeding schedules. Your easy babies are calm and relaxed. They do seem to follow predictable feeding schedules, but are also flexible with their day. Okay, so we see them as happy, friendly babies. Slow to warm up babies, they're not really wild about new situations. They're cautious, sometimes fussy, but they do warm up to a new stimuli or situations if they have repeated exposure to it. Habituation is a protective characteristic of the newborn that will allow them to become accustomed to their environment. They can determine which stimuli offers a learning potential, and they will ignore everything else. They will just internalize, turn away from it. Consolability is your newborn's way of calming itself down. In a crying state, your newborn will engage in different things to hopefully reduce its stress and calm itself down. Most notably, the things that it will do is hand-to-mouth movements, with or without the fist or finger sucking. So you may see it ball its fist up and just put its fist in its mouth or fingers. Sucking, specifically non-nutritive sucking, is soothing for the baby, and that's kind of where pacifier use came into play. If the baby was crying, if you put the passy in the mouth, it would start sucking and it would calm itself down. Now, a baby is determined cuddly if she responds to the parent's attention by turning into them, snuggling into the crook of the neck and calming down when the parent tries to console them. No two babies are the same, and some seem to cry longer and harder than others with less of a trigger. You got to remember that. A newborn's cry is its way of getting attention and trying to convey a message to you. How else is it going to communicate, right? Babies may cry for as little as 5 minutes or as much as 2 hours at a time. So I'm sure you can see why new parents would get exasperated if they had a baby that liked the 2-hour crying jags more than the 5-minute crying jags. Good news is that the amount of crying typically is going to peak around 2 months of age, and then it's going to start decreasing and getting less and less. Now, when a baby cries, he may be trying to say, feed me, change me, help me, or just hold me, okay? I am of the belief you cannot spoil a baby by holding it, okay? Definitely early on like this. There are 6 distinctive phases of the newborn sleep-wake cycle. Now, being able to regulate their sleep-wake cycles is a must for the newborn's neurobehavioral development. For the baby, the optimal state of arousal is the quiet alert state. Your newborn will maintain this quiet alert state with very distinct actions. You may see the baby actively withdrawing from any stimulation by increasing the physical distance, okay? So think of the baby that is being held and you're in the face and you're cooing and giggling and talking, and that baby pulls back. The baby may reject whatever is stimulating by pushing away with hands and feet, or it may turn its head, break eye contact, may fall asleep on you, or use signaling behavior such as crying or fussing, saying, leave me alone. Your newborn is going to sleep on average 17 hours a day, with the periods of wakefulness during the day gradually increasing as he matures and is organized with its sleep-wake cycles. And here in our last slide, we see the 6 distinct phases of the sleep-wake cycle that we talked about previously. You have the deep sleep, you have the light sleep, and here your baby can be more easily roused. The yawning, droopy-eyed, drowsy state, that's kind of where I am right now. The calm, quiet, alert baby. The baby that's wide-eyed, afraid to miss anything in the active alert phase. And then the one that's thinking, what in the world has happened this time, in the full-blown crying state. So we've taken some time and gone through our newborn and just kind of what our assessments and physical findings are with it. And if you have any questions about Chapter 16, then bring them to class. Thanks. We'll see y'all next week.